Hi everybody, welcome back to Facebook Live Q&A with the Kaldas Center. I'm Dr. Rami Kaldas, and we have been looking forward to answering your questions this month. And today I have with me our new associate, Dr. Peng Pei Wang, who joins us from New York City, where he did his training, and he has an amazing history. He's a fabulous surgeon. He used to be a urologist and then was doing kidney transplants. And now he has done his OBGYN residency and then a special training in minimally invasive surgery with a famous laparoscopic surgeon, Dr. Farnajat in New York. And we have the good fortune to have him as part of the Kaldas Center team now. And so he is going to help us out tonight.
Okay, how are you everybody? So I'm very, thank you so much, and I'm very happy to be here, and I'm looking forward to answer all of your questions about your health and wellness, okay?
So anyway, what I sure appreciate, we sure appreciate everyone who submitted questions already tonight, and if you have not sent a question yet, feel free to do so and post it to the Facebook Live, and we will do our best to get to it tonight. These go by pretty quickly. It's amazing how quickly they go by because we just enjoy talking so much with you. And so if you would like to submit an anonymous question, please contact us using Facebook Messenger and indicate that you'd like to share your question but remain anonymous. We welcome those also. Before we begin, a reminder that this Q&A is meant to be informational only, and if you have a serious health concern, make certain to contact your physician or give us a call for an appointment so we can help you out. If you'd like to contact the Kaldas Center, visit kaldascenter.com or just call us at 920-886-2299. During the usual business hours, we would be delighted to talk with you. So let's get started with the first question.
Okay, so the first question was from Patricia. And her question is are endometriosis and the endometrial cancer the same thing? So this is $1 million question. That's a very good question. So in one sentence, they are not the same thing. They are totally different things. So the endometrial cancer is a malignant disease. It's a cancer. And the endometriosis is a benign disease. It's not a cancer. So, but they come from the same place. They all came from the endometrium line of the uterus. You know, we have every female has a uterus. The uterus has 3 layers. The outside is serosa. In the middle is we call it myometrium. It's the muscle layer. The inside of the layer is called the endometrium. That's the cells, and every month give you the blood for the period. So the endometrial cancer is the cancer have the endometrial cells has a lot of gene mutations and became malignant, and they can spread inside the uterus and outside of the uterus. It's it's a whole so once you have the endometrial cancer, the main treatment is surgery. After surgery, we have different staging. And basically, the stage 1A can be cured by surgery itself. If there's stage 1B, you probably need to have some a radiation therapy. But the stage 2 or 3, you probably need chemotherapy as well. For the endometriosis, it's a benign disease, but somehow it still behaves like a cancer because it can spread as well. It can be invasive. Yeah. So that means all those cells, when they spread out from the uterus, go to your pelvic, and they can go further, go up to your upper abdomen. Sometimes can invade into your bowel, the bladder, and the ureter, and cause all those problems.
Well, now do tell. I wonder, is there ever a situation when endometriosis can actually turn into endometrial cancer?
That's great question. So actually, a lot of patients ask me this question before. Actually, from so far, the study shows the endometriosis cannot turn into endometrial cancer. They are totally separate. But however, the patient who has endometriosis they do have higher chance for ovarian cancer.
Okay.
Very surprisingly. So the normal population, the occurrence rate of the ovarian cancer is about 1%.
Mm-hmm.
The patient who has endometriosis, their like the chance, the risk for ovarian cancer goes up to about 1.5 to 2%.
Wow.
Yes.
Wow, that's an excellent answer.
Mm-hmm.
You can tell Dr. Wang has done a lot of research
Yes.
on cancer.
So yeah, we did
Oh
like
my goodness.
so about like the relationship with like endometriosis with ovarian cancer is a very hot topic. That was the research interest from my mentor, Dr. Farnazad. And so actually we're still working on like a review articles for this endometriosis and ovarian cancer.
Fabulous.
Mhm.
Thank you, Dr.
No
Wang.
problem. So the next question is from Janelli, I believe. So her question is, what are the symptoms of the uterine fibroids? That's also a very good question. The fibroid, as we call it like leiomyoma in the medical term, actually this is a tumor, the most common tumor of the females. I mean, talking about the tumor is a mass, but it's a benign, it's not malignant, okay? So in the it's most common in African American women. So before age 50, about like 80% of the 70% of African American women can have fibroid.
Wow.
And for the Caucasian woman, that number will go to 60%
Okay.
before age 50. However, not every uterine fibroid show up the symptom. So a lot of people have the uterine fibroid in their whole life without notice they have the fibroid until they do ultrasound. So about 1/3 of all those people have the symptoms. The number one symptom is abnormal uterine bleeding. Means when they have the fibroid, all those people, they tend to have heavy menstrual bleeding. Sometimes bleed between the period as well. So this is the number one symptom. The second symptom is the pelvic pain. So because the fibroid is so large, it's compressed the surrounding organs, and it's heavy, it's pushed the pelvic floor, it can cause a lot of pressure and the pain. And also sometimes, and although it's and the submucosa, because the fibroid can into different locations in terms of the muscle layers, and there's like a clearly study shows the submucosa fibroid, and if they twist the intrauterine cavity, they can affect the fertility as well.
I see. And so you're saying the submucosal fibroids are inside the uterus,
Exactly.
and they're going to be more symptomatic,
True.
and in fact affect fertility, whereas when they're not inside the uterus, but maybe on the outside of the uterus, they're less symptomatic. Is that what you're saying?
Now, in symptom, if we talk about the fertility, it is like a less effective. But still, like one of my attending actually from Mount Fever, he did quite a lot of study as well. He checked like more than 100 women with big fibroids.
Yes.
Okay, they are not the submucosa, but the intramural. So
I see.
he
So
said
in the
like,
wall then.
exactly. Like he said from his study, it shows if all those like the fibroids more than 6 centimeters, still somehow it affected the fertility as well.
I see. So how do you usually take care of fibroids that are symptomatic? Obviously, if they're not symptomatic and they're not too big, you just don't need to do anything about it. But because so rarely, there's tiny percentage, maybe 1 in 400 actually have a cancer in them. But so if the fibroid is inside, how do we take care of it at the Kaldas Center?
So if the fibroid, for example, is a submucosa and the patient comes for the infertility, and the first one we probably will do the hysteroscopy myomectomy.
Right.
So
no incisions involved.
Exactly.
Fantastic.
Exactly. And this is in terms of the treatment of uterine fibroid. That was very it's one of my research focus during my fellowship. So of course we can do like more conservative treatment and surgical treatment. So we basically divide into 2 parts. The conservative treatment we can give patient like hormone treatment. The strongest one is called Lupron. So you give the patient for 6 months Lupron, and the most of the time the uterine fibroid can squeeze the size in half size. But unfortunately, the Lupron has so much strong side effect, and the maximum we can give the patient about 6 months.
Well, I have a patient actually coming up who actually has a very numerous fibroids. The uterus is quite substantial, and she's coming up to us from Illinois, and she found us online like this, and so I gave her Lupron to shrink them at least, and that way when I take the fibroids out, it's just going to be a lot less time because we have to, of course, get them all out. And through tiny incisions, because we do our surgery almost overwhelmingly, all minimally invasively, either laparoscopically or hysteroscopically. Yeah.
But talk about the surgery right now, it's very interesting because we train as minimally invasive. So just like say, the surgery part, we can do laparoscopic myomectomy, we can do a robotic myomectomy. And the good thing is, for example, if the fibroid is too large, probably laparoscopic or robotic is not a good idea either, because you're going to spend long hours and going to bleed so much. So based on all those situations, my mentor, Dr. Nazatz, they invented so-called LAM procedure. It's called a laparoscopic assisted myomectomy. The idea is we're still going to do the laparoscopic first. We probably will look around the uterus to see if there's any adhesion, and if it's necessary, we can temporarily block the uterine artery as well.
Right.
Then we do a tiny, about 3 or 4 centimeter, incision at the suprapubic area. Then we take out the fibroid one by one.
I see.
Okay.
Fantastic.
So this is way so you can make sure you take all of the fibroids out in a short time and less bleeding.
Fantastic.
Yes.
Thank
It's
you.
called LAM. It's
Thank you.
LAM.
Fantastic.
Yes.
Hey, and the next question is from Susie. How safe are hormone vaginal rings, and can they be used for years? Well, just that they're a vaginal ring, Susie, is simply, that's their delivery system. And so it's like taking hormones with other delivery systems like a patch or orally, and they usually will have less side effects when given vaginally though, through a ring, because it's a controlled, sustained release, a very steady release of the hormone, and so you have a nice balance there. You can use them for years. There are 2 rings that we think of. One is for contraception for reproductive age women, and that's called NuvaRing, and that can be put in for a month, and tolerated very well. An excellent side effect profile, better than almost any oral contraceptive, and it doesn't pass through the liver, so it doesn't cause nausea and so on, and it's very close to the organs that it's affecting also. The other one is for menopausal symptoms. It's called estering, and that can be left in for 3 months at a time. Isn't that nice? Not having to take a pill every day. And yes, they can be used for years, but the same rules apply for all that apply for the other hormones. And so let's say you have a uterus, and you don't want to just put an estering in and forget about it, because that stimulates the endometrium and can cause precancer of the uterus. So you need to give progesterone to balance that out if someone has a uterus still, of course. So the same rules apply. That was just one example. But an excellent question. They are safe and they can be used for years. So just a reminder, if you would like to set up a time to speak with us at the Kaldas Center, just call us at 920-886-2299 or go to kaldascenter.com. Hey, well, Dr. Wong and I are ready for another question. All right. And so, from Amanda, do you think infertility treatment will be covered by insurance in Wisconsin in the future?
What do you think, Dr.
Oh, I'll take this one because I've lived in Wisconsin longer. I think that Wisconsin is has a proud progressive tradition. I won't go off onto the political tangent by no means. We don't want to do that. But Illinois has infertility treatment covered, and law mandates that. Now Wisconsin does not. And it is going to be entirely a political thing. And can the state afford it? I mean, Illinois is is the worst off as far as state budget of any state in the whole country. And it's not because of covering fertility therapy, making insurance companies cover fertility therapy, but they're trying to cover too much perhaps. And they're in a really, really big hole. And the mentality is to, that everyone should be helped. We need to get there as a state yet. And so I believe sooner or later it will be covered. However, I do believe that it's going to be a while. I don't think it's going to be in the next 5 to 10 years, unfortunately. So anyway, so from Devin, can you talk about endometriosis and the diagnosis and treatment of it? Well, you know what? Dr. Wong just finished his fabulous fellowship in endometriosis and with Dr. Farnajat, and he has all kinds of insight into fibroids and endometriosis. Prior to that, he did his training as a general OBGYN after being a urologist in a kidney transplant, before coming here from China. But anyway, so I'm going to let him take this question on endometriosis and the diagnosis and treatment of it.
Oh, this is very great question. So the endometriosis, to be honest, is a really weird disease and not familiar for the patients, not familiar to most of the GYN doctor as well, to be honest. And generally speaking, the patient presented the symptom until she was diagnosed as endometriosis. Generally speaking, take about 9 years because it's
9 years to
9
diagnose
years
on average.
Because it's so difficult to be diagnosed. And just bottom line, the diagnosis of the endometriosis, the only definite diagnosis is a laparoscopic procedure. Okay, we don't call it a diagnostic laparoscopy because very good hand you can make the diagnosis and the treatment at the same time. Okay?
Right.
So we call it a treatment laparoscopic treatment of endometriosis. And so literally it means you have to excise all of the endometriosis lesions by whatever you can see with the laparoscope. The good thing with the laparoscope, because the laparoscopy can magnify the disease.
Right.
And with your naked eyes, probably you cannot see all those tiny lesions. But with the laparoscopy, you can see them very well.
Just to interject there, because we do see an awful lot of people who have diagnostic laparoscopies first, and that's okay because so few people have been taught how to excise these lesions safely without causing harm.
True.
That is okay if your OBGYN does a diagnostic laparoscopy and is honest with the situation. True. And says, hey, I can't do this. Exactly. Let me send you somewhere where they can, like a Kaldas center or whatever.
I agree.
And so because otherwise it may cause serious harm. And so anyway, so what about that treatment of endometriosis? Boy, that's a book in and of itself.
Exactly. So the major treatment, of course, is the surgery, okay? So you have to make sure you excise all of the disease from the pelvic, but the surgery itself is not the end of the treatment. Because the endometriosis is so much rely on the estrogen hormone, and the young female, they continually generate all those estrogens. So you literally say, in 50% of the women in 5 years, if you don't give them the hormone suppression, they will have the recurrence of endometriosis. And
it's not only Lupron, though, that suppresses hormones. You can have less dramatic treatments than Lupron.
Exactly.
A combination of progesterone and letrozole is a good combination. That's the one that Harvard likes. And so I think that there are different approaches to minimize menstrual flow and therefore minimize that backwards flow of the menstrual blood and recurrence of endometriosis.
True. And also if you use the birth control pill to suppress the ovulation, you can decrease the chance of endometrioma as well.
Okay, and look at this question from Nikki. Hey, why is the laser surgery better than a cold excision or deep excision surgery for endometriosis? Well, I'll just start with this. I'll start with this. Thanks for the question, Iggy.
Yeah.
In fact, with laser surgery, that laser is simply our knife, and we are excising it completely. We simply use the laser to cut it out, and the reason that it's superior to cold excision is because the laser will coagulate vessels up to 3 millimeters, and so as you go, it coagulates and you keep a field that is not bloody. The more bleeding, the more char you have, the more scar you have. And so we're excising using the laser as our very sharp knife with minimal collateral damage. So when you do a cold excision, so essentially we're doing deep excision with the laser. The laser is simply our instrument. And when you just take scissors, laparoscopic scissors, and cut without any energy in them, you're going to get some more bleeding with that, and so you then you're going to have to burn with electricity to stop the bleeding, and so that may end up leading to more collateral damage, more scarring, then, Nikki. But what are your thoughts on this? Did I sum it up pretty well?
That's very good, very good. I like the answer, but still remember all of so it's. You use knife, you use scissor, you use laser, you use harmonic, all kinds of instruments you can use, but the bottom line, you have well-trained endometriosis the surgeon. Right. The surgeon itself is more important than the instrument, okay? So for example, if well-trained like Rami, and he has in this field in more than 20 years, he saw a tremendous patient, all kind of situations of endometriosis. So I believe you give him anything, he can excise all of endometriosis.
You're so kind.
I'm pretty quick with the laser. Yeah, I know. Rami is the best laser surgeon I've ever seen. And when I travel from East Coast to the Midwest, I never have ever seen any surgeon
you're very
use
kind.
laser.
Well, you're very kind.
But still, from my opinion, the surgeon itself, you have to find a good surgeon, well-trained expert in this field to get a treatment. So that's more.
And that goes for the robot also. The robot is just a fancy instrument. It's just like laser, just like a scalpel. So, hey, can you talk about endometriosis and the diagnosis? No. That's from Devin. I'm sorry. We already endometritis. It's not
sorry.
Hey, my apologies. I was reading too fast.
Yes.
Thank you, Devin. Let's talk about endometritis.
Endometritis is one part of the PID, the pelvic inflammatory disease. It's totally different from endometriosis.
Thank you.
Okay, endometritis is kind of for our genital tract systems. We divide the lower genital tract and upper genital tract. We divide it from the cervix, okay? So most of the time for the lower genital tract infection, we can talk about vaginitis and cervicalitis. But if we go talk about endometritis, that means above the cervix, that will go upper genital tract infection. Right. And we generally put them together as a PID. And most of the time, this type of infection came from the sexually transmitted disease like chlamydia or gonorrhea. And of course, people who has BV, the bacterial vaginosis, they also have the higher chance for upper genital tract infection because their ecosystem in the vagina is unbalanced, and some of the bacteria can go up.
Wow, and so if you have, endometritis essentially is, you're saying, inflammation of the endometrium, the lining of the uterus.
True.
And that could lead to some scarring in there, I bet.
Yeah, so the main treatment for this one is the antibiotics. So the standard treatment from the CDC for this one, so we have outpatient treatment and inpatient treatment. So basically, if the patient the symptoms is really mild, there's no high fever, not pregnant, no nausea, no vomiting, can tolerate oral medications, we tend to treat all those people as outpatient, giving them the antibiotics for 14 days. Okay. If they are very sick, okay, they cannot tolerate the medication by mouth, or they have appendicitis, they are pregnant, so we will tend to admit them in the hospital for 3 days, give them the IV antibiotics. Once the symptom is under control, we send them home and continue oral antibiotics.
Right, and of course you can get endometritis after having a baby there, and an infection of the lining. It's,
True. Okay.
and that needs to be treated so it doesn't cause issues in the future. And so thank you for that question. And now we have another question from Haley.
Okay.
Can you talk about why it may be more difficult for a woman with endometriosis to get pregnant?
Oh wow, this is a very, very good question. So the endometriosis is not really is the cause for infertility. 50% of the women who has endometriosis cannot be pregnant in their whole life. Or some people have like so-called sub-infertility. They have very, very difficult hard time to get pregnant. What's the reason? There are multiple reasons. The obvious reason is like because endometriosis is kind of inflammatory changes, and they can form a lot of scar tissues. They can block your tubes.
Right.
They can block they can have like endometrioma and decrease your reserve from your ovaries, okay? And also can get the scar tissue inside your uterus. This is from anatomy point of view.
Mm-hmm.
But the study shows that actually the adhesion of the endometriosis is not that important for the infertility. The major reason is the inflammatory changes.
Right, that inflammation
Exactly.
really somehow gets in the way of the egg and the sperm getting together.
True. So that's the reason why sometimes after we excise the endometriosis, the lesions, we decrease the level of the inflammatory, and the patient can be pregnant spontaneously by themselves without any infertility treatment.
Right, 80% of the time within a year after complete excisional therapy of endometriosis,
Exactly, yes.
the person is pregnant, 90% within 2 years.
True.
The benefit lasts for 2 years.
Great, yes.
And so from Aziza, I'm surprised by how many women I talk to with polycystic ovary syndrome and difficulty conceiving who don't tolerate metformin, don't know about ovarian drilling. Is it an uncommon treatment? Do you want to expound on ovarian drilling, doctor?
Ovarian drilling, in Kaldas Center, actually we do a lot of ovarian drilling. And if you talk about the treatment of PCOS for infertility, actually ovarian drilling is the best treatment. Of course, it is a last resource, okay? We always try all of medications. If of the other medication you try like Clomid, Letrozole, like everything, if it's still not working, and most of the time, the last treatment we do ovarian drilling, then patient get pregnant by themselves.
Right, and you're right, Aziza. It's like that people don't hear about it, and the reason is because prior to ovarian drilling, there was a wedge resection. That people would actually have incisions, big incisions, to actually go in and cut a piece of the ovary out, and then that would make the ovaries work better. Now, ovarian drilling is an extrapolation of that, but instead of cutting a piece of the ovary out, it's simply popping some of these dormant follicles that people with PCOS have, all right?
And also, I think that the best ovarian drilling is by laser here.
Oh,
this is so beautiful, you know?
Well, and part of the reason is because with the laser, you only have such minimal collateral damage.
Yes.
If you take electricity and pop those cysts, then you get a lot of damage to the ovary. A lot of damage, scarring. But with the laser, you have a 0.2 to 0.3, 0.2, can you imagine? 0.2 millimeter collateral damage beyond what you see. So that is like not even visible practically. It's just so little collateral damage.
It's so beautiful, with the laser ovarian drilling. I think this is the art.
So, all right, it looks like we are out of time already tonight,
this
Doctor.
is quick, you know.
Yep, it goes by so fast each time. Thank you, everyone who.
But I still want to talk one thing before we stop. So,
sure, please.
So because I saw so many people in my training or in the East Coast with the fibroid, and once they a little bit over 14 week size, 16 weeks size, and all of the GYN doctors tend to open surgery. Okay, if you say the uterus more than 20 weeks, 30 weeks, no doubt they will do open surgery. I just try to emphasize, okay, no fibroid needs to do the open surgery. Okay, no matter how big it is, so you can always do minimally invasive. The largest uterus we've done is 34-week size. Okay,
Fabulous.
34-week
That's
size
under the
uterus.
diaphragm.
Exactly. We still be able to do the laparoscopy, and the patient go home the same day. And we don't do morcellation inside the belly. We do something else. But don't, please. If any doctor tell you you have to do open surgery for fibroid, you have to think about it. So right now in this country, multiple doctors, they have the capability to do minimally invasive, either use a laparoscopy or use a robot or use lamb. So we can do minimally invasive. Please.
For the few doctors who are that skilled.
Please don't do open surgery for fibroid.
Well, thank you for bringing your knowledge and your skill.
Thank you.
From New York to Wisconsin. And so a quick reminder that if you'd like to speak further with us, visit thekaldascenter.com or give our office a call at 920-886-2299. And if we did not get to your questions tonight, we will follow up with you in the next few days online. As for tonight, thank you again for spending time with us, and we hope you have a wonderful evening.
Okay, thank you so
Good
much.
night.
Bye-bye.